Ladies and gentlemen, distinguished colleagues, first of all, let me thank the organizer for kindly inviting me to this meeting. And the title of my presentation is What will be the future of antihypertensive treatment? And I think that this issue revolves around a persistent problem for antihypertensive treatment. That is the fact that in real life, the percentage of hypertensive patients in whom blood pressure is not controlled is very small, as you all know. These are data for a very well-known study, very large study, and you can see that overall, in that study, only 13% of people with hypertension under treatment had blood pressure controlled below 140/90 millimeter mercury. And this poor rate of blood pressure control is responsible for the very well-known evidence that hypertension still remains the major cause of death worldwide. What can we do about this? Well, new drugs effectively lowering blood pressure is, of course, an important aspect of research in this area. And you see from this nice review published in 2015 that indeed very many drugs have been and are under investigation, revolving around different mechanisms to reduce blood pressure. And among them, some of these drugs in the years between 2015 and today have been widely investigated, and they are still ready for medical practice. We know, for example, that the vasopeptidase inhibitors plus the addition of an angiotensin receptor antagonist, ARNI, is an effective antihypertensive agent and provides some additional benefit, for example, in people with heart failure, both with reduced ejection fraction and with preserved ejection fraction. Most of these patients with preserved ejection fractions have a history of hypertension. Then we have new drugs for the treatment of resistant hypertension, for example, non-steroidal mineralocorticoid receptor antagonists. And then we have, and this is a very important advancement in research, the SGLT2 inhibitors, which have been shown in recent years to be protective in heart failure, to be protective in people with renal disease, not only in diabetic patients, but also in non-diabetic patients. And in addition, these drugs have a quite clear blood pressure lowering effect. These are data from empagliflozin, and it shows that these drugs, empagliflozin in this particular case, is capable of reducing ambulatory blood pressure by 3 to 4 or 5 millimeter mercury, which is not a minor effect. And this can be obtained also in patients with antihypertensive medications, including diuretics. So these drugs are ready to be used for a variety of conditions, not only limited to diabetic patients, helping to further and more effectively reduce blood pressure. But I would like now to turn to another point, and this is, of course, new drugs will be useful. Of course, they will add to our ability to control blood pressure, but the drugs we have already are quite effective in lowering blood pressure, particularly if used in combination treatment, because hypertension is a multifactorial condition, and there are multifactorial mechanisms controlling blood pressure. So the more mechanisms we can recruit, the greater is the chance to lowering blood pressure effectively. And you can see data from a very large database here, in which adding a second drug to whatever was the first drug was associated with a very, very marked increase in the number of patients achieving blood pressure control. And if we use 3 drugs rather than 3 drugs, among the current therapeutic armamentarium, you can really obtain very marked blood pressure reducing effect. This is, for example, data from a combination of an ACE inhibitor, a diuretic, and a calcium channel blocker from a quite large study. And you can see that 2 drugs, 3 drugs added to the combination treatment were capable of further reducing blood pressure by something like 20 to 30 millimeter mercury. And in people with a marked elevation in initial blood pressure, grade 2 and 3 hypertension, the effect of triple combination treatment was greater than 40 millimeter mercury. So the therapeutic means we already have to lower blood pressure are quite remarkable. New drugs are welcome, but we should use, at the best of our possibilities, the very important therapeutic armamentarium which we already have. And this is the big problem in current hypertension real-life treatment. Because low adherence to antihypertensive treatment in real life and high inertia, they concur to low use of combination treatment in real life, which is responsible for the poor rate of blood pressure control today. This is an example, but I could show you many other examples from several countries. This is my region, the region where I live, which is Lombardy in northern Italy. And we can calculate data from the database of 10 million people, including all citizens. And you can see in red, in the red histograms, the percentage of patients using combination treatment of at least 2 drugs after studying these patients for 3 years. And please notice that regardless the age, the sex, the clinical history of these patients, the co-treatments, about 2/3 of the patients remain in monotherapy. So they cannot use the important blood pressure lowering effect of combination treatment. And I think that this is the single most important factor explaining the poor rate of blood pressure control. Is not the inability to have effective drugs. These are available, but the fact that these drugs are not properly used, and the proper use of drugs means to use drugs in combination. Now, because of this, the 2018 European guidelines try to introduce a novelty in the treatment algorithms. That is to start treatment with 2 drugs and move into 3 drugs, thereby shortening the titration phase, which in itself improves adherence. And whenever possible, use combination treatment of 2 or 3 drugs as a single pill, because in this study, in which single pill combination works compared with combination of the same drugs but given separately, as you can see, those using a single pill combination had, regardless the age, the sex, and the clinical picture of the patient, they had a significant increase in high adherence to treatment and significant reduction in the percentage of patients showing low adherence to treatment. But in addition to this, if we start using 2 drug combination at the very beginning of the treatment strategy, we can have a greater blood pressure lowering response in a faster fashion. And as you can see from this post-hoc analysis of the value study, patients having a faster blood pressure control within the first month, they had a lower rate of disease compared to patients in which control was achieved, but later in time, not within the first month, but after the first month. And this is again data from the Lombardy database showing that people prescribed monotherapy and follow them for 3 years. After 3 years, only 36% were on combination treatment from initial monotherapy. Now, remember that guidelines suggest that 80–90% of the patients should be in combination treatment on the long term. Of course, if we use two-drug combination at the beginning, the problem is bypassed because people are already in combination treatment at the beginning. And in this study, as you can see, 80% or more of the people continue to be on combination treatment for 3 years. But then adherence is even better when combination treatment is used as first-step treatment. Here you see the risk of discontinuing treatment, which is very common, unfortunately, in the hypertensive population, compared to initial monotherapy in people starting treatment with 2 drugs. And you can see that there is a very clear-cut difference. The number of people discontinuing treatment when treatment consists of initial combination treatment is much less than the number of people discontinuing treatment when they start treatment with a single drug. And in this very nice study from the NHACE database in the United States, as you can see, compared to individuals starting treatment with 1 drug, those starting treatment with 2 drugs, 1 year later, had a significant greater number of patients achieving blood pressure control, presumably, I believe, because of a better adherence to treatment and a lower therapeutic inertia. And there are now several observational studies showing that in people starting treatment with combination treatment and continuing with combination treatment, the risk of cardiovascular events is less. And this is, again, a study from the Lombardy database in more than 200,000 patients, showing that the treatment strategy based on initial combination and continuing combination treatment is the one which is capable of saving a greater number of patients. Let me now finish with another question, however. Now, we search for drugs and treatment strategies that lower blood pressure more markedly, the only goal to pursue for future antihypertensive treatment. Well, we have to remember one thing which has been known since a long time, and this is indeed an almost historical study because it was done about 25 years ago. And it compares mortality in individuals in which antihypertensive treatment controlled blood pressure quite satisfactorily for those times, compared to truly normotensive subjects, normotensive without treatment. I would like you to notice that patients with hypertension in which blood pressure was apparently well controlled continue to have, those in yellow, a mortality rate which was greater than truly normotensive patients. And this is called residual risk. That is, unfortunately, even when blood pressure is apparently well controlled, hypertensive patients continue to have a risk which is greater than normotensive controls. So future of antihypertensive treatment should aim at having more effective antihypertensive drugs and a larger, wider blood pressure control, but look also at other factors which can further reduce risk in patients achieving blood pressure control. And of course, the first factor which comes to our mind is the fact that hypertension almost seldom comes alone. It very frequently has a lot of comorbidities and co-cardiovascular risk factors. And several possible further interventions in hypertensive individuals are under study to try to see whether we can reduce residual risk beyond the effect obtained by achieving blood pressure control. And I would like to complete my talk by talking about something which looks very interesting and perhaps even possible to be achieved in real life. That is to pay great attention to consistency of blood pressure control during treatment. Now, these are 3 different large studies, post-analysis of INVEST, on target, and value, in which what we did was to look at the incidence of cardiovascular events according to the time the patient spent during the years of treatment under blood pressure control. And data were, of course, adjusted for the mean blood pressure value throughout the treatment period. You can see very consistently for each study that the greater was the amount of time in which blood pressure was controlled, and this was calculated by control value at blood pressure measuring visit, the lower was the incidence of cardiovascular events. Patients having blood pressure control for more than 75% of the treatment time had less events, almost half, than patients having control in only 25% of less of the treatment time. So the problem in the future will be to organize physicians' work in a way that they can control whether patients not only have blood pressure control as a mean value over a number of years, which in clinical practice doesn't mean much, but they have persistent control visit after visit. And this will be a difficult goal to be achieved because so far, control is inconsistent. And in my last slide, you see the data from the ELSA study, and you see control of office blood pressure, percentage of patients achieving control of office blood pressure every year, and this was about 40% of the study population. But in red, you see those having control over the entire 4-year period of the study, and this was much less small number, about 1/3, which means that most of the patients have control 1 year, but not the following year, or vice versa. So if we want to increase the protective effect of reducing blood pressure, we should probably in the future use a number of markers which are different from mean blood pressure values throughout the treatment period. One of them could be to trying to really pay attention to consistency of blood pressure control. Thank you very much for your kind attention.